Good morning. I'm Dr. Pierre Fenaux from the Department of Hematology of Hôpital Saint-Louis and a PHP Nord in Paris. And the issue is the role of CPX-351 in MDS. MDS has been, well, before the advent of hypomethylating agents, was relatively, I mean, in some patients at least treated with intensive chemotherapy, the classical 3+7, that led to remission in about 50% of the cases, but remissions were relatively short, with a median of, well, less than 1 year. So it was a good treatment to bridge patients to transplant, patients with excessive blasts, in particular more than 10%, to bridge them to transplant. And this type of chemotherapy is still the recommended one before transplant, at least in patients who have no complex karyotype, because complex karyotypes do not respond very well to chemotherapy. So what is the advantage of 3PX351? It is a liposomal chemotherapy, which appears to be superior to the classical 3+7 in secondary AML, or in AML with what is called MDS-like changes, especially with regards to morphology or cytogenetics, and therefore may have some superiority. But in this context, is better tolerated. The duration of myelosuppression may be somewhat longer, but there is far less mucositis, hair loss, etc. So, especially in patients above a certain age, this is an interesting treatment. So what we did at the Groupe Francophone des Myelodysplastic, the GFM, was a phase 2 trial in 31 patients who had high-risk MDS and generally more than 10% blasts. Their median age was 63, and they were treated with CPX-351, the classical schedule, on days 1, 3, 4, 5, the typical dose. And I mean, what can be said is that most patients had normal karyotype. So there were only 2 patients with unfavorable karyotype. And most of them were candidates for transplant. And the response rate was 87%, which is very good. I mean, only 2 or 3 patients did not lower their blast count initially. And in those patients, the response, the complete response rate depends on the criteria you're using. If you use the classical IWG 206 MDS criteria, the complete remission rate is only 23%, because those criteria are very stringent. But now if you use the AML criteria, which are somewhat less stringent with regards to cytopenias post-transplant, the complete response rate is 53%. And the other patients had a decrease in blasts with no complete improvement in cytopenias. But importantly, 29 of the 31 patients could be bridged to transplant, which is I think a very good achievement. Now, the duration of myelosuppression was up to 50,000 platelets was 26 days, and up to 1,000 neutrophils was 28 days. So it may be somewhat a little longer than with classical chemotherapy, but that's not even sure, because we know that classical chemotherapy in MDS as compared to AML leads to more prolonged cytopenias. And so there was no, I mean, there was no death due to treatment. No patients had to be transferred to intensive care unit. So 29 patients were transplanted. Follow-up remains relatively short. We had 4 transplant-related mortality and 1 relapse before transplant, actually. And so and very little mucositis, hair loss. So for the patients, it was more comfortable, clearly, than a 3+7 chemotherapy. So it's it's a positive experience. Now, of course, those were candidates for transplant. Those patients did not have complex karyotype, and only one had TP53 mutation. So this treatment may not be adequate for patients with complex karyotype, TP53 mutation in the context of complex karyotype, where potentially a hypomethylating agent-based treatment may be better, in particular the combination of azacitidine and venetoclax, which appears capable of reducing the blast count, including in patients with complex karyotype and TP53 mutation. So, but it seems an interesting approach. And at this ASH meeting, a US group confirmed overall our results. And in addition, we had the full dose used in AML, and it was tolerable. So you don't need to reduce dose in those patients. And if if patients are not transplanted, you can continue with consolidation treatment with 2 days of CPX-351, then 1 day if you, that's the idea. But once again, in our trial, almost all patients were bridge to transplant.